Consider's Hospital, Bangkok. And he's currently working in the Department of Diagnostic and Interventional Radiology in BNP and Kist Medical College. He's also an executive member of AFIKM. He's one of the first neurointervention in country Nepal, and it's really been a good job currently. Over to you.
Thank you, sir. Let me first apologize for my croaking voice, having laryngitis with a chest up voice. So anyhow, I hope you all can understand. And good morning to you all. I would like to thank the scientific committee for choosing this topic, spinal cord fistulas, spinal cord shunts, because I believe this is one of the really best discussed topic it goes to the discussion of neuro interventions. One reason is some of the incipient spinal shunts are never diagnosed until you do the spinal angiogram. We can suspect from MRI, but unless we do a proper spinal angiogram, it may not be properly picked up. So that is one of the reasons why she is still underdiagnosed. So let me begin my topic. So when we talk about spinal vascular shunts, either they are fistulas or malformations. And fistulas are either dural AV fistula or intertumoral. And it's always good to have this RODIS classification in mind, because this helps in managing the patients in a holistic approach. I will come to this classification later. Now, how do we approach a spinal fistula? Spinal shunts. So whenever in MRI or clinically we have a suspicion, clinical suspicion, radiological suspicion of having a shunt in spinal vasculature, that we first, next step is to identify what is the feeding artery. So now if the feeding artery is radicular-laryngeal artery, then we suspect that this is a durable AV shunt, and the location is usually atrial. And now if the feeding artery is radicular-medullary artery, or say the radicular-bile artery, and we go for the Nidus architecture. So in Nidus architecture, like I said, either it is a fistula or it is a globus. If it is a fistula, then we evaluate what is the shock volume. Now, shock volume is usually evaluated indirectly in MRI from the architecture, angiomodulation of the venous and arterial architecture, or better evaluated from the angiography itself. And now, if it is low fistula, then it is microfistula. If it is high-grade shunt, then it's macrofistula. And if it is you see a close, then it is a glomerular valve. Now, if you don't see a shunt, then we diagnose it canon. Now, from radicular-laryngeal coming to radicular-medullary, you see that the location of the shunt is from epidural to intercrural extramedullary port. And then we have to have an idea whether it is acquired or congenital. So shortly recapitulating our anatomy, we have longitudinal axis, anterior spinal axis, which are made up of the radicular-medullary feeders from different levels. Likewise, we have two posterior spinal arteries fed by radicular-bile arteries at different levels. And one thing I would like to emphasize is in many textbooks we have been finding that how they describe the anterior spinal artery supplies the anterior third cord. But actually, anterior spinal artery supplies central third. We have to keep in mind because the central area supplied by the anterior spinal artery is predominantly motor area and explains symptoms of our patients. So this is the area of the anterior spinal artery and of posterior spinal arteries. And nidus can be single or multiple. And even if it is a single nidus, feeders can be multiple. So we don't stop in our angiogram when we find one nidus and its feeder. We keep on probing so that we rule out all the feeders. That's one of the tricky part in treating spinal. And the venous drainage, we have longitudinal major longitudinal drain by anterior medial view and posterior medial view. There are radial veins from intramedullary parenchyma and an extensive bile network of the veins. So most of the time when we diagnose or suspect spinal shunts is what all we see is this dilated venous by the venous lines. We may not see the globus itself, we may not see the fistula itself, but how we suspect it, we see an extensive dilated remodeled venous channels. Now what is the pathophysiology? So wherever there's a shunt, what happens is the normal parenchymal venous drainage gets impeded because of the shunt. And there is congestion in the pancreas. Now this congestion may lead to spinal edema, which we can see in MRI, or we can see the hemorrhage itself. And mostly with the close or large fistulas, which have and ectatic venous pouches, they may exert a spaceable bile effort. And the shunt may cause a stiff denum. These are the basic pathophysiology, how the pieces get symptoms in spinal shunts. The fistulas again get symptomatic usually in the Shunts-RADCON hemorrhage because of her location, which inside the very location, easy to blink. Glomerular AVL they become symptomatic either by venous congestion alone or also they may important hemorrhage. Clinical features, normal deep weakness, paresthesias, and the shunt located in bonus medullaris, the present problem dysfunctions and spasming the back being there. Now, the glomerular type of shunts, we may see a nidus. 80% of the shunts are these type of shunts, predominant bacteria. What we see in by MRI, we may see the globus itself. We don't see the incipient globus. And in shunts, in fistulas, there is a tight fistula between the venous side and the arterial side. Can be anteriorly with the anterior spinal axis or posteriorly with the posterior spinal arteries. And these make the lesser amount, like 20%, no gender difference, usually present in the second decade of life, and then we see it to the shunt point. So like I said, we have either low shunt or high shunt or fistulas. Low shunts are microfistulas, moderate in large spin needles, and they're within arteries and the cleansings. They're 90% of all fistulas, commonly found in thoracic and lumbar. The bolus medullaris and final terminal may present with progressive myopathy. That this is a typical low shunt type of fistulas. High shunt fistulas are less common, but they are more aggressive. They need to massive remodeling of the episodes and usually associated on hereditary hemorrhage, telangiectasias. So this is one of the approaches why we should see the genetics of some fistulas as well. So these are the remodeled venous draining teeth. In macrofistulas, they sometimes are so big and high trouble that they can remodel into bone itself. And then let's proceed to investigation. We know MRI is the modality of choice. What we all can see is dilated perineum intramedullary located vessels through voids. Sometimes we see venous congestion, sometimes we get confused for longitudinal living stensic transverse modalities, kind of stuff. But then we have to detect the port edema, and sometimes this is the one that we the guy just suspecting that there's a fistula. But the thing we don't see when MRI is precisely the location of the communication, usually in the intact. Contrast is helpful. use it in subtle dilatations. And now this like MRA, MRA give good picture and you picture the angio-articular and you don't show the arterial features. But then gold standard remains spinal angiography for diagnosis and treatment planning. So we treated. The goal of treatment of spinal shunts is to obtain a neurologically intact patients after treatment and any angiographic risk for further symptoms should be only treated. All symptomatic shunts are indications for treatment. Now, how do we treat? The endovascular embolization is the modality of choice, the therapy of choice in all fistulas and in glomus type of malformations. Liquid embolic agents are the treatment of choice and non-adhesive degradable materials, especially for the glomus types. Surgery is always an outcome, and then for the holistic approach, we need medical treatment as well. In fistulas, the aim of treatment is to obliterate the point of fistula. And how do we do that? The most secure way is identifying the most proximal venous segment together with the most distal arterial segment. This is the key treatment of the fistula. And that's why we need to know, it's important to know where the artery stops and when the shunt is located, when the vein stops. How do we find it? The transition between artery and vein may be indicated by a large venous pouch, typically in large volume shunts, and in low flow type of shunts. There's a slight change in the timeline from the transition from artery to venous side. And great caution must be taken in identifying the normal spinal cord arteries. This is the most important part of treatment spinal shunts that can lead to preserving normal spinal cord arteries because we may have render the patient pathways for him. In global type agent is the pretty embolic agents like sweets or mix. Sometimes we find the angiographic risks in the angio-articular like a 4.8 point incidental aneurysms that has to be managed. Even if we don't need to treat the whole observation like it's just in friend in him. In venous congestion, we need to reduce the shunt. That's all we've done to anything else, we need to reduce the shunt for it. How do we diagnose venous congestion in the angiography? Well, the parallel normal flow will take a moment, 20 seconds. This is the definition of venous congestion with angiograms and angio. Post-embolization always look for obliteration of the vessel, patency of anterior spinal axis. Venous drainage of the spinal cord should be normal, should be random normal. Over-penetration glue, which will guide single venous vein, and the heparin, intravenous heparin for the next 24 hours. Complications in the water series, there were transient complications up to 40%, but it's additional has been reported up to 11% permanent applications. So this is it's always good to keep the genetic classification. I come back to this by the time. I would like to share my cases. So this was from 18 years old. We were on a refer from HRDC with progressive weakness of both lower limbs. She had also equinus deformity from left foot. Spine shows hereditary channels. So, and this chevron shows that there's a no-feeling type of shunt. With all this dilated channels, reticulometer leader, which is dilated itself. And then there is extensive dilatation of these channels. So we see this is the transition with all the venous dilatations. So it took out of my catheter all the way up to the shunt and gluing embolization. So we can see that the shunt is gone with the intact reticulomedullary. So this is post-embolization.
and total patient. Starting when you start over here, but it's different.
Sustained. Another case is 46-year male with numbness of alternate 2 years. We suspected and shunt here. Otherwise, obviously, is the diabetic channel that's supporting it.
What did it?
Bilateral T10 to L4 segment and arteries and bilateral internal iliac. This is what we need always to check for the internal iliac means. This is T2 wrong. So there's a fistula here. From the right to be beyond venous conditions. So what we see from is there is a fountain in the forest. But like I said, we need to keep approach all the features on this. So we look for the median cycle and then drop the natural cycle, we see another thing. But some was the same. She does the hospital. Superstatic deck. This is during the rejection. Post-skew is undiscarded in this condition as well. So mere from the lateral cycle was insolubilized. So take home messages, we need to keep in mind out of core German spinal shunt and the genetic supply. Because there are genetic hereditary, germinal, genetic somatic, and then can be forced. You need to keep in mind the hereditary hemorrhagic telangiectasia, and I could not discuss about the metameric syndrome because of time, but just to have a brief idea of this genetic approach is real. And some types. Thank you for your take that.
Thank you. No doubt because a nice presentation, nice cases. Any question from audience? So I have one question. Apart from stool, many objective on the especially the Europe side, they are using particles for embolizing the spinal area. So what is your thought regarding the non-glutamation of the spinal?
Actually, in my trend in Suriname, we used to have a lot of spinal, but practice there was also a bit. I've never seen it using particles, especially in English to that. I don't think actually in aerial as I know like we need to see the angio architecture and then decide. Because avian is also a shunt. And if the draining side is large camper,